everyone. It's the top of the hour, so I think we are going to get started here. I know there's still a few people signing on. We have a lot of interest in this webinar today, so I'm thrilled that everyone is here. Before we get started, if you have not already done so, please remember to mute your phone line by pressing 4*. And then as we get towards the end and we get to questions, if you wanted to unmute your line at that point, press 5*. And the instructions for that are in the chat. Additionally, we want to make sure that everyone, of course, gets the CE credit for today. And in order to do that, we need a couple of things. First, please go ahead and chat in your name and the organization that you're with, so we have that in our files. But additionally, there will be a survey that's going to be emailed to everyone on the line today at the end of the presentation. That survey it's a short one, just needs to be completed, and then you will receive your CE credits for that. There's also a link to it if you didn't want to wait for the email. That's in that web link section that's right below the presentation. That's towards the left-hand side of your screen. This one's towards the middle of your screen. And additionally, if you wanted to print out the copies of the slides for today, that's also to the left of your screen at the bottom under Files. Everyone can have access to that. So while we get started here, I wanted to introduce our speaker today. Our speaker is Dr. Calvin Yu. He is our subject matter expert in this discussion today on just a primer on the entire topic today on the disease, risk, and mitigation, which of course we're all working towards here. And I know this is a topic area that's of interest to everyone in the state here. Dr. Calvin Yu is the Chief Integration Officer with Kaiser Permanente Southern California, and in that role is responsible for navigating the integration of quality, patient safety, continual preparedness, and research with health policy and regulatory requirements. He's an infectious disease fellow and has just a wealth of experience to be able to share with us today. So with that, I'm going to pass it over to Dr. Yu. And as he's speaking, if there are questions that come up, please don't hesitate to type in your questions in the chat box. We'll be monitoring that throughout the presentation, and we will make sure that your questions get answered. So we didn't want you to feel left out or not to feel like this was a back and forth conversation, because it most certainly is. So please don't hesitate to chat in questions. So with that, Dr. Yu, go ahead.
Great, thank you. So today we'll be discussing some new research and sort of a amalgamation of older research around the nation and actually worldwide on Clostridium difficile and sort of the pathophysiology and how to deal with this. I think we're struggling in the United States because our antibiotic use is one of the highest in the world, and so I did add on a part about antibiotic stewardship, which is timely because Senate Bill 1311 requires all of us in California to have a particular elements of stewardship. I want to have a special thank you to Drs. Steve Perotti, Drahansky, and Rieg. There are a couple slides that are included in here that are from their talks that they've given at either county, state, or national level on the same topic of C. diff and antimicrobial stewardship. So today will be, since of the first slide I switched, if someone can verify on the chat that the slide switched. So the objectives are to understand the pathophysiology of C. difficile infections, describe risk factors for C. diff, describe strategies to mitigate this disease, and then understanding the epidemiology and how that relates to antibiotic overuse, particularly in California where we have a state law that speaks to antibiotic overuse. Clostridium difficile is a spore-forming anaerobe bacteria. The reason why I'm calling that out in the beginning is that the spores are pretty key in understanding why there is so much transmission. And basically, when someone ingests the spores, the gut can be colonized with the spores, but in order for it to really activate and create the toxins that cause the inflammation and the disease, there has to be a change in the gut environment, and that change is usually induced by antibiotic administration. It may be surprising, but this has been documented for a couple of years now at least, that there are asymptomatic colonizers out there in the community, 3% and even higher. In hospitalized patients, since they are in an environment where there is more C. difficile and perhaps more chances for contamination, that estimate is higher at around 20 to 40%. And this is a pretty scary concept because if we have asymptomatic carriers, we don't necessarily know, and the patient may not even know that they actually are shedding the spores. So, as many of you know, Clostridium difficile causes anywhere from a mild to severe diarrhea. It can lead to a life-threatening colitis. At its worst, it can cause what's known as toxic megacolon, which is basically the colon is so inflamed that there is no forward flow, and that eventually the internal pressure in the lumen of the gut increases to such an extent that there might be intestinal wall perforation. And then you get fecal spillage into the abdomen space, and that is a surgical potential emergency. Clues of severe disease, I think everyone knows the existence of a small bowel ileus, a high white count. They may evolve into full-blown sepsis with organ dysfunction, particularly renal failure, and you may see pseudomembranes on biopsy if a GI doctor does a colonoscopy investigation. So this slide I don't want you to worry about. It's very busy, but I only included it because it really gives a visual picture of what's going on that is invisible to the naked eye when you see an actual C. diff patient. So in order to have a C. diff patient, we must realize that that patient at some point when they were not sick ingested those spores, and whether it came from an asymptomatic carrier in the community or in a hospital, it really doesn't matter. They ingested the spores somehow, and then there's a change in the gut flora by the administration of antibiotics, and then they get the full-blown disease due to activation of the C. difficile and the toxins. And so if you focus on anything, focus on that smaller graph on the bottom where you see a theoretical patient that gets admitted for diarrhea and is treated for C. difficile. So obviously there's shedding of the spores in the community with the diarrhea and also in the hospital with the diarrhea. But you'll note in the break in the dotted line, even when there's resolution of diarrhea after treatment, there is still some spore spreading onto the bed rails, onto the nurse call button, the environment of the room. And this is the reason why environmental cleaning is so important, which we'll get into later. The tests available are varied and multiple now. I think the most sort of media attention grabber is the PCR toxin now, because it is a more rapid and extremely sensitive test. In fact, it's so sensitive that you could have a positive PCR in a liquid stool sample, and the patient may not even have active colitis. So the point here I want to make is that the diagnosis of C. difficile really is one where you use laboratory diagnostics in conjunction with your clinical acumen and clinical correlation. And this is slightly ironic because the NHSN has, for a while, chosen to define hospital onset C. difficile purely by lab definition, right, after 72 hours of admission. And, in reality, on the clinician level, what we deal with is we really marry the diagnostic technique of the laboratory with the clinical suspicion and the clinical exam and history of the patient to actually diagnose a C. difficile case. So I just wanted to really delineate the differences between the two because it sometimes creates problems for healthcare systems. The mortality in the United States, at least, has only increased since 2001. And, this is part of the reason why C. difficile is such an issue. The other reason is that we have more people with health care now more than ever. And it's estimated that the U.S. annual hospital healthcare cost for C. difficile is anywhere between $1 to $3 billion. And to the point that some of these hospital onset C. difficile cases may be preventable, hopefully collectively as a healthcare community we can put a dent in that number. The C. difficile disease can also, it's been documented to increase the length of stay, the length of ICU stay, and therefore, since they're staying longer and sometimes requiring a higher level of care, the additional cost for having a C. difficile case also rises. And I think this is not any news to anybody, but there are references there and numbers for your perusal. So risk factors. So, because of the costs to the patient, the family members, and to us as a community of healthcare providers, the concept of risk stratifying your particular patients in your hospital and pre-identifying those that are higher risk for C. difficile or bad sequelae of C. difficile disease is attractive. And the medical literature under this quote unquote old information has tried to define this in the past. And in general, it's been said that those that are elderly, so greater than age 65, or those who have multiple comorbidity, those that are exposed to a lot of antibiotics, and most recently proton pump inhibitors like omeprazole, formerly known as Prilosec, were thought to be high contributors. But what we've worked on, at least with these two publications that we did here in Southern Cal KP, was to try to refine those sort of vague risk factors. And so we published two studies that showed that, okay, in terms of age, it's greater than 68 years. And so, greater than 65 or greater than 68, not that big of a difference, but the concept of getting more granular data so that the frontline clinicians have something to work with is a little bit attractive. And so the length of stay, we know that we have always felt as infectious disease clinicians that the longer the patient stays in the hospital, the more at risk that they will get C. difficile. I think nurses, physicians all think that way. But it's nice to quantify that. So we have a study that showed that greater than 24 days has a higher risk. I think something new that we bring to the table is we have a lot of different ethnicities that we serve in our organization. And so if you're white, non-Hispanic, and particularly white, non-Hispanic female, you have a higher risk. Interestingly, Asians have a lower overall risk, but if they should get C. difficile, they have a slightly higher risk for mortality. I think that's an important distinction and something that hasn't, to my knowledge, been reported in the medical literature before. And as far as multiple comorbidities and the old information side, so we've actually demarcated what those are, at least within our system. And I think we're pretty representative of what's in California, as we insure 1 in 5 people in Southern California at least. And so those other comorbidities are dementia, peripheral vascular disease, exposure to skilled nursing facility, and exposure to 3 or more classes of antibiotics within the same hospital stay. And then finally, and this will be no surprise, but it's nice to really actually document this in a formal study, this concept of hospital onset C. difficile, we understand that that's reportable, but if you really want to get to the heart of mitigating this disease, just reporting your hospital onset or just focusing on it in your C. difficile task force locally at your own hospitals, it kind of misses the boat because many hospital-associated C. difficile cases actually manifest now in the outpatient side after they're discharged, especially now, right, when healthcare around the country is moving to a paradigm of hospitalist specialists where, they have they're charged with taking care of patients and discharging them on average with less hospital days total, which means formally diagnosed hospital onset C. diff may actually manifest itself after discharge as an outpatient. And so it's important to remember the continuity of care, and if there are any hospitalists on the line, that you are doing a discharge to make sure that they follow up with the appropriate people once they are discharged. So this is a slide that I liked in 2005 when it came out, and then slowly over the last 10 years, I I think most infectious disease doctors found this less and less helpful. But initially it was very helpful. So this is a relative risk of the type of antibiotics and the risk of C. difficile. And so here you have cephalosporins, and at the time there were only 3 generations of cephalosporins. Fluoroquinolones, at the time it was really mostly the UTI fluoroquinolones, so Cipro and norfloxacin. Clindamycin, that's fine. That's always been clindamycin. And macrolides. But flash forward 10 years to now, 2016, there are now 5 generations of cephalosporins. Instead of just Cipro and norfloxacin, we have moxifloxacin and levofloxacin, which are used for different disease states. It's usually mostly used for pneumonia, not urinary tract infections. And there's also multiple macrolides used. So this is less and less helpful as we evolved over time. And so we worked on sort of providing, get ready for a busy slide. So this is out of what we published in Infection Control and Hospital Epidemiology. So I just want to point out a few things. One is that, so we've obviously broken out a lot of just broad class drugs, as the prior slide showed, into more specific slides so that it would be more helpful for the frontline clinician. So for instance, instead of a broad bucket of cephalosporins being high risk, we've actually shown that first generation cephalosporins, like cefazolin, I think is the most well known, actually has a low risk, especially compared to a third generation cephalosporin like ceftriaxone or cefotaxime. And so that distinction is important, and therefore we should no longer lump the cephalosporins altogether as being the highest risk, because there is differences between the generations. The macrolides, we validated that they are actually low risk. That's important because azithromycin is being used for community-acquired pneumonia quite frequently. We also validated that the fluoroquinolones are high risk as well. So there are nuances, particularly if for tetracyclines and doxycycline, those are extremely low risk. So for instance, if you're treating a community-acquired pneumonia patient and you used to do something like ceftriaxone or cefotaxime plus azithromycin, you may opt to do ceftriaxone and doxycycline instead of the azithromycin, particularly for a patient that had a prior history of C. difficile. So it's a little bit more extra thinking and more information on which antibiotics to choose depending on the risk factor of your particular patient, particularly if they had a history of C. difficile. So I think this added information, although looking very busy, I think for the hospitalist and inpatient infectious disease doctors that this will actually be more helpful than the prior slide, because we are breaking out to single antibiotics and groups of antibiotics within a larger group. We also, on the bottom right, you see if you're exposing a patient to 3 or more different classes of antibiotics within the same hospitalization, that greatly increases their risk of C. difficile. So I think that's also helpful information to the frontline clinician. So here's just a basic 3-bullet summary of what the medical literature shows in terms of antibiotics and C. difficile. So bullet point number 1, the overall reduction of total dose as well as the number and days of antibiotic exposure and the substitution of high-risk antibiotic classes for lower-risk alternatives may reduce the incidence of hospital-acquired C. diff. And so that was published by a group in Clinical Infectious Diseases in 2011. Our work that we published in the last 2 years I think expounded upon that idea, and we showed with a little bit more granularity the types of antibiotics you could switch and what was more riskier than others. And then, as I just stated, that the number of total antibiotics exposed during a hospital course also increases the risk. And the third bullet point is basically out of the CDC guidelines for antibiotic stewardship. They say that the ASP teams can help pick the most appropriate antibiotics in the fastest amount of time to help avoid both extended length of stay, duration of antibiotics, and multiple antibiotic exposures. So that fits and ties in nicely stewardship with C. difficile mitigation tactics. So we know that we overuse antibiotics in the United States. The CDC in the last 3 weeks actually came out with a very media-friendly statistic that 30% of all antibiotics are thought to be overused in this country. And so what do antibiotics do exactly to help increase the risk of C. difficile? So basically, our gut has natural bacteria in a large quantity, a specific composition, very diverse, that helps us as we age from infants to adulthood with the ability to have a healthy gut, maintain good integrity of the intestinal wall, and the ability to resist infections should we ingest something that is infectious and alien, and including colonization with C. diff. So people that are colonized with C. diff and don't have a problem have a healthy natural gut flora at baseline. There are about 100 trillion bacteria that colonize the gut and are essential to keep and maintain this homeostasis. So this is a complex ecosystem of bacteria living with us, the human beings, as the host, to keep the integrity of the intestinal wall intact and the immune system locally functioning. This is all altered when we administer antibiotics, because as you know, when you give antibiotics, whether through the IV or you ingest it, it goes everywhere, right? So to treat the foot cellulitis, for instance, it eventually gets to the foot, but it also eventually gets inside the gut and kills off the good bacteria and alters this nice balance that we naturally have. And that facilitates an environment where the C. difficile can propagate, create toxin, and cause the colitis that we know so well. So the link between antibiotics and C. difficile is pretty clear. I just wanted to summarize, since we are in the state of California, that Senate Bill 1311 was much more informative than the prior Bill 739, which basically just stated that every acute care hospital needed to have a stewardship program. That was pretty vague, and I think a lot of us struggled with what exactly does that mean. Senate Bill 1311, I believe, was meant to clarify that. And so stewardship teams should have a physician lead. There should be a pharmacist involved. That stewardship group should be using their information to help educate the medical staff. And there should be a working committee that oversees the stewardship roles and responsibilities and reports to a higher administrative level committee by the year 2016. So I think you're all familiar with this. If not, you should get familiar because it's basically by June 2016, which is coming up. If you want to refer to the ideal way to build a stewardship and what they look at, the CDC and SHEA basically have these bullet points here listed. So they would recommend to look at the patterns of usage of broad-spectrum antibiotics. They prefer a specific way of measuring consumption in DDDs or days of therapy. They want us to look at our drug resistance patterns at your particular hospital and the class-specific antibiotics that might be driving that resistance, and do a periodic risk assessment for each hospital, and to use that information to educate your frontline staff. That's a lot to do. The Senate Bill 1311 addresses some of these, but not all of these. But that's sort of the ideal goal of stewardship. And so what we did within our organization is we took those marching orders because it's mandated, right, by California state law, and we tried to incorporate as much of those tenets as possible. So we do have a pharmacist on our stewardship teams. We do have a physician, as stated on Senate Bill 1311. And basically the rubric we found the most helpful, and I've spoken to other hospitals outside of KP that also find this helpful, is that the pharmacist really is taught which cases of opportunity, which target antibiotics, which clinical cases are typically serve as opportunities for more appropriate antibiotic use after they're admitted. They'll do the surveillance and pick the cases so that they can maximize the physician time. And then they'll set about an hour or two to round with the physician. The physician can further look into the microbiology data, get the latest results, and determine whether a more optimal antibiotic can be chosen. And if they think think so, then they'll contact the attending physician who has the right to refuse or make the recommended changes. And we found this to be helpful. One caveat I want to say, particularly for those smaller hospitals, is that the particular physician you choose or that is involved, it's much easier to get buy-in if that physician is already established. And so, for instance, there's one large private practice hospital that I had prior connections with who, they chose a private practice physician to be on their infection control committee hospital staff and to sort of champion stewardship for a couple years that he was on. And, the rotating private practice physician is always someone held in high esteem. If they get their buy-in, then, sort of by osmosis, the rest of the staff find that program to be more legitimate. So if you're in the process of creating your stewardship program, I think that bit of information might be helpful. So we did a 2-hospital pilot, one with our tertiary large hospital and our smallest community hospital in Southern California at the time, and tracked over a year pre and post stewardship the differences. And you can see we decreased the needless use of anti-pseudomonals by quite a bit, anti-MRSAs, quinolones. And I think any infectious disease trained physician would say that if you could decrease these types of medications, that we're doing a pretty good job. We also did an analysis of, so these are the 2 pilot hospitals. They both, despite one being tertiary, one being community hospital and being small, decreased the percentage of antibiotic consumption about the same, about 20%. And then compared to the year prior. And then we compared those 2 pilot hospitals to 3 of sister hospitals that didn't have a stewardship or had a stewardship but lost their pharmacist component. And you can see compared to the year prior that they used far more antimicrobials than the pilot site. So we feel like that was a sort of validation with this model. We also, so this same data, and this goes to show you, who your target audience is and making your slides compatible with your target audience. This slide I like to use for administrators, and I have used at outside conferences where it's the same data as the prior slide, but basically you're showing the worth of an ID pharmacist. So the graph at the top in the pink is a hospital that up until that point never had a stewardship program, and you can see them consuming antibiotics at a pretty consistent rate. At the bottom, you have 3 hospitals that had stewardship in the format that I just described with an ID pharmacist and a physician, and they're using similar but almost 2.5 times lower rate of total antibiotic prescriptions. And then in the middle, you have a hospital that had a similar program but lost their pharmacist component, and they're in the middle. So this actually, and this is good for CFOs who may not have medical training, but they certainly know dollar signs. You pretty much get what you pay for. If you have half of your physician pharmacist team, you're going to get half of your interventions. And so hopefully this will help those of you that are trying to build business cases for your stewardship programs to make that point. So in 2012, we spread this stewardship model in all of our Southern California hospitals, and we focused on multiple targets. They're all anti-pseudomonal drugs as a group. And you can see that we decreased the needless use of anti-pseudomonals by quite a bit. We also threw up a volunteer, so it wasn't mandatory to look at this quality status chart, but it was available for people to look at. And, it has a gold star, a check, and then this big ugly red X if you were a high utilizer. So I think this is an example of the power of sharing data. And so, we blotted out the medical center names, but I think this concept is something that Callahan, this organization can use, because it's really powerful to really have a little bit of peer sharing of similar data, because then you can get best practices out of the so-called high-performing hospitals, and then you can address sort of the low-performing hospitals, and both of those are in quotes, such that we can get closer together. And so over the years, this discrepancy between the usage has shrunk a little, at least within our own hospital system. And I'm hoping with this Callahan consortium that you have going that you can do the same thing without actually calling out the individual hospital. So for instance, you could be hospital X or hospital Y, and only that hospital would know that that was them. So again, an example of sharing data for a greater good. So we had a very short period opportunity to actually look at our consumption data for inpatient antibiotics in the orange, that's us, with 11 teaching hospitals in the red and 92 community hospitals in the green. Because when we did our regionalization of our stewardship program, we knew we were decreasing certain key classes of antimicrobials, and we didn't know where we stood. So this is, again, the power of sharing data. So quinolones, we were doing a pretty good job compared to the rest, similar with piptazo, which is very broad and very much overused throughout the nation. With CRE, carbapenem overuse is a big concern, and we were doing pretty well. We were just like the community for vancomycin, pretty much, which seems to be a hard one to decrease. And so that was helpful, sharing, contributing and participating in that and sharing data. And part of the reason why I'm giving this talk today is sharing data is good. One thing I want to say about stewardship is that what we did in our workflow is we just did what was right for the patient. So I know a lot of people think of stewardship as taking away antibiotics, and yes, that's our biggest intervention. You can see circled here that we increased the dose. Sometimes if we felt like it was warranted and the patient would benefit, we broadened and escalated the spectrum of antibiotic coverage in particular patients if we thought anything. We actually proactively changed antibiotics to avoid C. difficile or renal insufficiency based on their history. And we also got to some diagnostic information, laboratory information before the rounding physician. And so this is really a quality and patient safety initiative and not just a remove antibiotic initiative. So finally, we published our pilot in 2014, the results, but we also did an assessment of mortality because we wanted to show, because that was one of the big questions when Senate Bill 739 came out, is how do you know with the stewardship program that you're not causing more harm? And so we looked at the pre- and post-stewardship hospital standardized mortality ratio. And for all these ICD-9 codes you see on the left, and at the time we were using ICD-9, we saw a decrease in the mortality of sepsis, bacteremia, and C. diff. Respiratory infections, we saw a decrease in mortality, and the sepsis overall mortality decreased as well. So although this was not designed to show causality because it was not a randomized controlled trial, it did show that we were not causing harm, and perhaps we were even helping to decrease the mortality rate of those infected with hospitalized and infected. So speaking of antibiotics, the treatment of antibiotics is to give more antibiotics, but specific ones. So we know for mild disease, metronidazole is given orally. Severe disease has sort of shifted in the last couple of years. The Shea Society sort of defines severe disease as having a white count greater than 15,000 or creatinine 1.5 times higher than that person's baseline. And that if you met that criteria, that you would go straight to PO-Vanco. I think a lot of infectious disease specialists would say these days that if you're in the hospital and hospitalized and have C. difficile, that's serious enough and would go straight to PO-Vanco. So I see a lot of that in the community and also academic centers. And particularly for ileus or toxic megacolon, it's a combination of oral or per NG tube, vancomycin, IV flagyl, and a surgery consult. Treatment options that I see being done around the country, and really the medical literature is really stagnant and not very convincing, is intravenous IG, IVIG, vanco enemas. I know a lot of our surgical colleagues like to use that, but I don't really see very good medical evidence published that those actually help. The rifaximin drug chaser with vancomycin is done in the community. Again, not that great data in the medical literature. Probably the best is fidaxomicin, which actually did a clinical trial, and it was shown to be non-inferior to oral vancomycin and perhaps maybe decrease the rate of reoccurrence of recurrent C. diff. I think the most interesting is the so-called stool transplant. where you basically take someone else's stool and you put it either through a colonoscopy or through an NG tube into the patient with recalcitrant C. difficile. We've now had a few years experience with that methodology and have seen people with C. difficile recurrent, very sick, receive this procedure and do very well. So I think that is actually probably one of the best bets for the future. And in fact, you may have heard in the news there are some partnering with private companies to make C. difficile pills, where it has, the bacteria inside and you just swallow the pill. So I think that's very interesting and something that will become more into play in the future. The last bit about prevention and what we can do realistically has to do with infection prevention and environmental cleaning. So ideally, you would want a single room and a single bathroom for your patient with C. difficile. Not going to happen in a lot of hospitals because, particularly in the winter months where bed issues are more prevalent. Barrier precautions, isolation precautions, is a way to protect yourself, the healthcare worker, and other people from being exposed to the spores. The terminal room bleach cleaning with 1 to 10 diluted bleach is not to be underestimated. We'll get into that in a minute. But particularly washing your hands with soap and water, that's the key. The soap and water washes the spores off. If you use alcohol gel, the gel does not inactivate the spores like the bleach does, nor does it actually wash off the spores off your hands like the soap and water. And so I've seen actually outside of KP some hospitals that with a C. difficile patient, they'll put like a surgical hairnet over the alcohol dispenser, just to remind people when they round and see that particular patient with C. difficile to not use alcohol gel. So I think that's a very smart and cheap way of reinforcing hand hygiene with soap and water for those types of patients. So as an infectious disease specialist, I want to share something with you that we saw in one of our smaller hospitals, and that's this idea of using different tactics or combination therapy, if you will, to control C. difficile. So if you harken back to the 80s and 90s with HIV, you may remember, those of you who are old enough to remember, that AZT alone did not halt HIV. AZT plus DDI did not halt HIV. It wasn't until we had a triple cocktail drug regimen where we were able to control and get a handle of HIV. And the three drugs attacked HIV in different manners. So I want to extend that analogy to C. difficile. And what I'd submit to you is you have to do multiple things and sort of address C. difficile in multiple ways in order to get a good handle of it. So this is, at the time, one of our smallest hospitals in Southern California, where they had a C. diff issue, and they initiated stewardship at the very end of 2011 and had some gains. There was a PPI reduction. At the time, there was some evidence that PPI overuse, like omeprazole, that's proton pump inhibitor, use would increase your C. diff risk, and we saw a little bit of a gain. We toyed around with procalcitonin restricted availability. That didn't really do that much. But the EVS bleach cleaning, when we validated the cleaning, that's when all of those happen at once is when we had a handle on C. diff at that hospital. And so what I would say is that the control of C. difficile is multifactorial, and it's a combination of good hand hygiene, EVS bleach cleaning, and judicious antibiotic use that really gets you there. And so we share best practices a lot. I want to share something with you that I've shared at some national conferences, the importance of bleach. So this hospital did something similar to what I showed you with the other hospital, where they got a hold of control of their high C. difficile rates, and then they had a sudden spike. And so they went back and looked at their antibiotic consumption. It was the same, nothing had changed. They looked at their hand hygiene rates, observations, and that hadn't changed. And they finally looked at the EVS cleaning carts and found that inadvertently there's a change in EVS leadership at that particular hospital, and the bleach cloths were replaced on the majority of those cleaning carts with something that looked very similar. It was also cloth, but it didn't have bleach on it. And it also smelled weird too, so people thought that it was actually bleach, but it wasn't. And so that was the reason why we had a spike in that particular hospital, and then they, of course, reinstituted the bleach cleaning, and it went back down. What that showed us and what that did was it unintentionally mimicked a study done in Northern Europe where they had purposely in an ICU initiated bleach cleaning, stopped it, initiated and stopped it, and each time they stopped it, they had a spike in C. difficile. So don't underestimate your EVS department and what they can do in helping with C. difficile. And so the last thing I'll go into is this environmental contamination because it relates to EVS. So symptomatic C. diff patients, 49% of the time, almost half the time, will shed spores that remain in that room. The more scary thing to me is that the asymptomatic colonizers, so these are people that we might not even know are colonized with C. diff, also shed spores at a pretty high rate, considering that they're not symptomatic, 29%. So that when they vacate the room, if there is not adequate cleaning, there's a higher chance that the next patient will get C. difficile. That's been documented in the medical literature. This contamination rate varies from 2.5% to 75%, so it really depends on how great your cleaning is or how poor your cleaning is and the type of patient that was in that vacated room. And just remember that the spores last up to 5 months in the environment. So people think of HIV as something scarier than C. difficile perhaps, but HIV virus itself in the environment doesn't last for more than a day. The C. difficile spores can last up to 5 months. So it gives you an idea of what we're up against as far as this disease. So there's this concept of prolonged isolation until the patient leaves, even if they're done with the therapy and are staying longer in the hospital for other reasons. And that's because the spore shedding can continue up to 1 to 4 weeks after completion of treatment. And I know this sort of butts heads with room availability and ER throughput, which is also looked at by regulatory agencies like the CDPH when they do the GACH surveys. So it's really up to your hospital administration on where they want to go on this, but just be aware that the spore shedding can continue even 4 weeks after the treatment and after the diarrhea resolves. So basically, there are 3 pillars to controlling C. difficile. The hand hygiene with hospital administrative support is crucial. The contact isolation and EVS cleaning validation, crucial. And judicious antibiotic use, important, but just having one of any of these 3 is not going to do it. And so I think that's important. So again, combination therapy for C. difficile. We're arriving to some questions. So I'm just going to read these, and you can answer. I think you have a little, if you're seeing what I'm seeing, you have a little screen to answer with. So which of the following may help prevent spread of C. diff? A, washing your hands with alcohol. B, bleaching the rooms after the patient's discharged. C, washing hands with soap and water. D, there's no need to use gloves when entering the room. Or E, both bleaching the rooms and washing hands with soap and water. So 91%, 94%, okay, the majority of you, 97%, are choosing B and C. That is the correct answer. Ultimately, 97.3%. Excellent. Next review question. Which of these antibiotics is considered high risk for C. diff? This is a little bit unfair because I just cold clocked you with new data that we published. So A, Cipro, B, clindamycin, C, ceftriaxone, D, doxycycline, E, ciproclinda, ceftriaxone have a higher risk than doxycycline. Well, this is kind of exciting for me in a geeky way, seeing the numbers fluctuate. So actually it looks like, yeah, so people are paying attention. So most are choosing E. Ciproclinda, ceftriaxone have a higher risk than doxycycline. Almost 80% of you chose that. That is the correct answer. So again, we have more finesse information now for your frontline clinicians on what to choices of antibiotics, better choices for patients in terms of C. diff. Which of the following are potential reasons why C. diff remains an issue in many acute care hospitals? A, antibiotic overuse. B, uneven room cleaning. C, C. diff spore shedding even after the diarrhea stops. D, all of the above. Everybody got that right. And final question. Antibiotic stewardship is required by California state law. What can small hospitals do to prevent C. diff? A, reinforce hand hygiene. B, focus on one broad-spectrum antibiotic for overuse. C, ensure EVS is cleaning C. diff patient rooms. D, contact isolation precautions for a C. difficile suspect. E, all of the above. And 100% E, all of the above. And so I want to end sort of with this. So with B, focus on one broad-spectrum antibiotic for overuse. You are not going against the California state law. You are not going against the CDC recommendations. One of our smaller hospitals in Kaiser, Hawaii, when we were regionalizing our stewardship model that you saw, they did not have the resources to do a full program. And so what they pitched was they had one broad-spectrum antibiotic that they really felt was being overused, and they just focused on that for 1 year. They looked at the results, presented to their leadership, and they got a little bit of pharmacy time to help them out. And so they added vancomycin to that, did it for a year, presented to leadership, and then they got more time for a pharmacist to help the physician out. And so over a period of 3 to 4 years, they have a full stewardship program. So it's okay to start small. You will note in neither the California state law nor the CDC recommendations does it say specifically that you have to do 7 antibiotics or all of them. It just says judicious use of antibiotics and justifying it through your local antibiogram. So you definitely can start small and build business cases. Hopefully I presented some data that can facilitate that as well. So this is not just a pharmacy or infectious disease infection control program. C. difficile control and stewardship involves everyone from the chief executive all the way down. We need stewardship programs not just for C. difficile, but due to multi-drug resistant organisms, to preserve our anti-infectives for our hospitalists and ICU docs, to have a full arsenal of antibiotics to help keep our patients safe and to cure them of infections that they get. So rather than view this as sort of a policing program, I hope you view this, those of you who are administrators, as a self-assessment, as a quality enhancement. For those ID doctors that are in private practice that might be on the call, instead of looking at this as impinging on your specialty, maybe you can contribute to stewardship, and actually this is a new niche for infectious disease specialists. Maybe you can build a business out of stewardship since it is required out of California state law. And the final thing I'll say is sepsis is a big national campaign getting people on broad antibiotics fast, and I totally agree with that. But the ramifications of that is that people get admitted from the ER on broad-spectrum antibiotics. What I would argue is that the stewardship is the great equalizer to the sepsis campaign, and hopefully we can influence C. difficile rates with stewardship plus good hand hygiene, good infection prevention program, and a good EVS program. That's it. I'll take any questions you might have.
Dr. Yu, thank you so much. This was fantastic. And while I'm waiting for folks to either chat in a question into the chat box that we can talk about, or if you wanted to just speak out, you can unmute your line by pressing 5-star. Press 4-star to unmute. Apologize for that. And you can ask a question. But this, honestly, this was not just a primer on prevention of C. diff and an antibiotic stewardship program. This was really a primer on basic quality improvement too. And I so appreciate that. I think the points that you made about transparency and about the importance of building reliability into your program, building the business case by customizing your message for, when you're trying to build an ROI, or return on investment, for bringing in an ID pharmacist. Just phenomenal points to be making, and I think all of us can use that information here. So really, really appreciate that. as well as the look at the bundle of prevention, just like we look at the other bundles of care in prevention of harm. This was great, and I appreciate it. Some of the simple ideas too, the visual cues of covering up the hand gel for patients in isolation too, so we understand. Remember that the hand gel is not going to work for these patients too. Just really, really good. I'm looking to see if questions are being typed in. I don't see them yet. I'll pause for a moment to see if there's anyone that is unmuted that would like to just speak out too.
I see one question. Do you mind if I address it?
Please do, yes.
So the antimicrobial stewardship program team meets monthly or weekly. So that's not hardwired into California state law or the CDC recommendations, but just to give you an idea, we find quarterly helps because it's nice to accrue quarterly data. Also, the reason for that is during the winter months, and I actually removed this slide for time reasons, but during the winter months, we definitely see an uptick in the rate of antibiotics being used. So we actually normalize it per 1,000 patient days. So it's a real increase of antibiotic consumption during the winter months, and so that usually happens in quarters. So it's nice to have those quarter blocks of data to assess the program with.
There's a question here. Can you address the question about probiotic use?
Yeah, that's interesting. So the medical literature on probiotics has gone back and forth for the last 8 years. And there was a meta-analysis done recently where it looked like it was swinging back towards in favor of probiotics. But a couple of things I want to say about that. Probiotics are best used, as the name indicates, proactively. So if you're starting someone on an antibiotic, probably it's probably less effective if you start the probiotic on day 10 of therapy. What I see a lot of community docs doing is in the outpatient side, if they're giving a antibiotic for pneumonia, they will also recommend probiotics right off the bat. The one thing I do want to warn you, though, is there have been case reports of lactobacillus, which is one of the main probiotics, of getting into the blood system and actually causing a true bacteremia, and even one case of endocarditis that I can remember in the medical literature. But those are in immune-compromised patients and patients that have perforated intestines or had recent surgery in the intestines. So you could, if you wanted to institute a probiotic campaign, just make sure that those patient populations are excluded. And, it remains to be seen how well that works. There's a question on UV light. Yeah, so we did a pilot on UV lights in both Northern and Southern California, and so the evaluation of that, the data was not conclusive. I think the concept of UV lights is good. I think the problem we ran into is that the particular vendor we were using, the UV light actually didn't get around, how toilets are circular, it didn't get around to the shadow areas. I did see a product recently at ID Week where there was a UV light distributor that actually addressed all the shadow areas. So I think that's also something that might be in the future, but I haven't seen anything definitive in the medical literature. So examples of validating EVS cleaning. Yeah, so someone typed in GlowGerm type equipment. So yeah, so we do use GlowGerm. So for those of you who don't know what it is, it's this powder that to the naked eye you don't really see, but then you can shine UV light or a type of special light afterwards, and it'll glow. And so what we did to validate EVS cleaning is either the EVS manager or the infection control manager or some the nursing DA would go in before the EVS cleaning and put the GlowGerm in specific areas that we know that we wanted cleaned, and then let EVS do their job. And then afterwards, shine the light and see, if we saw any of the GlowGerm powder. And so we gave that feedback to our EVS colleagues, and that's how we really beefed up our cleaning from the EVS services. And, I'd like to point out that we really included them in the conversation. It wasn't a policing. It was really, we showed them the 3 pillars. They are a full 1/3 of how we control C. difficile. And we told them people are dying of this, and the nurses and doctors can't do it by themselves. We really need you guys to be on board. And they really appreciated that. So we turned a potentially contentious situation into something that was team building, and I think that's the way to do it.
Excellent point. I couldn't agree more with that there too. And I think anyone that can share also here how they have included EVS as partners in this too, we would love to hear from that, as well as any of the other examples of how sites are validating your EVS cleaning would be great. And even if you think about it after the webinar too, if it comes up, please share those with your clinical improvement advisors, because we would love to be able to collect all of that and make sure we get that information out to everyone, because we really can all learn from each other in this. This is going to take a big group effort to make a big difference across the state. I see a couple others are typing in too. While they're typing, I also had a question for you, Dr. Yu. You spoke earlier on about hospital onset versus hospital-acquired C. diff. How are you seeing hospitals get this information about hospital onset once the patient is discharged from the organization?
Well, so I'm really referring to hospital-acquired, not hospital onset. So hospital onset is what we're all reporting to the NHSN. That's the cases that happen after 72 hours after admission, and they're still in the hospital when that C. difficile positive stool is sent. What I'm referring to is this national trend to this hospitalist system, which I think is good, because they're trained in inpatient specialty care. But a lot of them are very into the shortest stay possible, which again is good. It's necessary for us as a nation to be able to afford health care for a lot more people. But what happens then is they'll discharge patients, and so that their hospital-associated C. diff might manifest in the outpatient setting. And so that's not required necessarily to be reported to NHSN, and that's harder to do if you're not integrated in a system like we are. So all I was pointing out is that C. difficile can still happen related to a hospitalization even after they're discharged, and that therefore the follow-up appointment is crucial. Definitely.
I see another question here too, that one of the complaints with bleach is damage to equipment. What are your thoughts on hydrogen peroxide, peracetic acid combo products?
Yeah, I've heard different stories about this. So one thing you might know is that I worked a little bit at NYU where I got my professorship, and so they were actually toying with this. They actually use hydrogen peroxide, and they were spraying it on. Well, actually, so they have a very home hospital, and there's instead of having separate patient rooms, they had to use these curtains. I think we're all familiar with that, right? So you have a large room, you use a curtain, and one patient's on one side, the other patient's on the other side. They use this peroxide spray on one unit predominantly to replace the bleach, particularly because they had an old hospital and they were experiencing some corrosive damage over decades, and it didn't quite work out. So that's anecdotal. I'm not aware of any really good studies that have shown the hydrogen peroxide product to be superior to bleach.
And then I think we have time for one more question here. I see one in the chat box. Can you comment on a problem of community-acquired C. diff and implications for hospitals?
Yeah. So one of the things that in our paper that we wrote about when we were sort of delineating how much of our C. diff was actually hospital-associated but happened after discharge is that you have this situation where the patient is potentially shedding a lot of spores and nobody really knows about it. And So this speaks to that one slide where I was showing that sort of increasing community colonization of C. difficile. I think if we don't address this as a healthcare community, we're only going to see more community colonization of C. difficile. And as you know from the CDC, and actually the White House spoke up on this last year, outpatient antibiotic use is just as bad, if not worse, than inpatient antibiotic use. So you can do the math. If there are more people colonized with C. diff spores unknowingly, and then they're taking a lot of unneeded antibiotics on the outpatient side, we're going to see some pretty big outpatient problems with C. difficile. So I think more hospitals are joining forces, and this Calhan organization is a good example of as a way of doing business or sharing quality data. And I think if we put this on the map as on a radar, and eventually hopefully we'll get to measuring outpatient antibiotic use too. Hopefully we can address that.
Wonderful. Well, I know we've come to the end of our time here too, and I just really appreciate you taking the time to share all this. This has been really, really helpful for us. We had some great discussion here, and even had some comments from folks, really wanted to make sure that this would be recorded so they can share it with other folks in their organization. And yes, this has been recorded. The recording will be available in a couple of days and posted on our website so that you can go ahead and share this, please, with others in your organization. You don't want to be a prophet in your own land, being the only one having heard this. So make sure that we share this. So with that, though, I would just like to thank Dr. Yu so much. This is wonderful, and also to encourage those to complete the evaluation at the end of either by clicking that link, the web link for the survey, or when it comes to you in email after this. So with that, thank you so much, and have a great day, everyone.
Thank you. Bye-bye.
The host has joined the conference.